everybody. Welcome to Osteo Bites. Happy Thursday. It's been a couple weeks, so we're glad to be back. Hey, we are super excited today. My name is Christina Iptoma, and I am mom to Osteo Angel Dillon and the Director of Scientific Programs at MIB Agents. And today on Osteo Bites, we are talking with Dr. Parthasarathy, who manages the 3D printing lab at Nationwide Children's Hospital, which provides comprehensive patient-specific treatment, planning, and device development services from a pediatric perspective. And she's going to be discussing virtual surgical planning and 3D printing in pediatric musculoskeletal oncological resections. And I'm so excited just because this isn't a topic that we talked much about on Osteo Bites. So thank you so much for joining us today, Dr. Parthasarathy. And we are thrilled to have you. And thank you also to Vicky and Walker for joining us as our panelists today. Vicky and Walker are both osteo warriors and members of our MIB Agents Senior Advisory Board. In fact, Vicky is our president this year and Walker is our vice president. So super great for them to join us, and I'll let them kind of introduce themselves a little bit and tell you a little bit more about themselves. But first, I wanted to introduce our guest today. Dr. Jayanthe Parthasarathy is a trained dental surgeon. She's practiced dentistry in India for more than 3 decades. And she transgressed into additive manufacturing for clinical needs after completing a master's in mechanical and manufacturing engineering from CEG and a university, and pursuing a PhD at the University of Oklahoma. And she has been at the cutting edge of 3D biomodeling and 3D printing to arrive at patient-specific solutions for complex surgical challenges in the adult and pediatric population for more than 2 decades, specializing in the development of patient-specific devices using advanced design and manufacturing technologies, such as 3D printing, with in-depth knowledge and experience in navigating FDA approvals for medical devices. She worked in the medical device manufacturing industry, specializing in the development of patient-specific implantable and non-implantable devices using advanced design and additive and subtractive manufacturing technologies, and was the key architect for developing an iPad app for surgical planning for surgeons' review and approval. She started and currently manages the point-of-care 3D printing program servicing clinic, research and non-clinical requirements enterprise-wide at Nationwide Children's Hospital, Columbus, Ohio, one of the largest pediatric specialty hospitals in the country. And she's passionate about teaching and leading related projects to undergraduate and postgraduate medical and engineering students. And she's guided more than 50 postgraduate students in dentistry and engineering. Her current research interests include materials for 3D printing or simulation of human tissues, understanding of mechanobiology, fluid flow, the blood vascular system, and virtual extended reality for enhanced visualization of human anatomy, all geared towards improving patient compliance and treatment outcome. So welcome to everyone joining us today. Please feel free to add any questions you have for Dr. Parthasarathy to the Q&A. I have a couple other announcements. Factor is June 22nd to 24th in Atlanta, Georgia this year. Registration will open shortly this month, and abstract submissions, we're taking those now. Those are due February 24th, just less than a couple weeks away. And we also have travel awards this year, and applications for travel awards are due April 7th. And to make sure you stay on top of all the news about osteo, about MIB events, subscribe to our newsletter. You can do that by going to our website at mibagents.org and clicking on the Join Our Community button. And then you'll hear from us once a month in your inbox. All right, let's get started. Walker, if you wouldn't mind going ahead and introducing yourself, that'd be great.
Yeah, hi, my name is Walker. I'm part of the MIB Junior Advisory Board, and I had a limb salvage surgery, like total knee replacement, and I think 13 centimeters of my tibia. So.
Hi, everyone. My name is Vicky Hoy. I'm the Junior Advisory Board President. I'm currently a freshman at Villanova studying finance. And after finishing treatment in May, I had limb salvage in November 2021 and was fitted with a 3D printed internal pelvic prosthesis. And thank you for joining us today, Dr. Parthasarathy.
Thank you, Christina, Walker, and Vicky, and others who are here. I really appreciate this opportunity. to be with you all this afternoon to speak about 3D biomodeling and 3D printing. And so nice to hear that Vicky has a 3D printed device after the surgery. I'm really excited. And I had the 3D printing program at Nationwide Children's Hospital in Columbus, Ohio. And we started this program about close to 6 years ago. And it's been very interesting working here. Disclosures, I have nothing to disclose. And I think Christina gave me a good introduction. So she gave a good surgeon of ours, a dental surgeon, and then moved on from orthodontics over to doing 3D printing and being here at Nationwide Children's today. Me with you all today. Today we're talking about three important things. We're talking about innovation. We're talking about the benefits of personalized medicine. And we're talking about outcome. Technologies have changed over the years. And we see that things have been moving. And we see first it started with CTs, X-rays, and how people used to see, but now we're looking into 3D printing and modeling. And we look at innovation. What do you mean by innovation? It's a practical implementation of a new idea. Personalized medicine uses patient's unique anatomy and requirements and customizes the device for the patient. Outcome is the results of treatment. So we'll see how these are affected by 3D printing, how we can do better. When we look at osteosarcoma, we have the stakeholders are basically a group of persons. We have the physicians, we have the patients, families, and the care team. All of these people, each one looks at it from a different perspective. And we as providers have to do the best for all of them. First, we look at the patient. The patient is in pain. They have swelling. They have difficulty in using, and they're anxious. They're like, what's my next step? How am I going to become okay? What's happening? What's going on? Then we have the families who are happy, who were running along with each other, having fun times. Suddenly, with this child getting sick, they get concerned. They start getting anxious. They are like, what's going on? What is to be expected? What's going to be coming in the days of the months of the years to come? And everybody keeps hoping for a miracle to get back to baseline as soon as they can. 1 second. Next, when we look at we said the physicians. The physicians and the care team by themselves are many. This one patient is looked on by so many people. You have the medical oncologist, you have the radiologist, you have the orthopedic surgeon who's going to do the surgery, you have the radiation oncologist going to do the radiation if as needed, and you have the pathologist who's going to take a look at the biopsies and say, and even during the surgery, they are going to look at the specimens, and they're going to see whether you're in a clean area or the surgery needs to resect some more. And yeah, the care team consists of the nursing team, radiology techs, radiation therapists, social workers, and medical device manufacturers, not to be the least. They form a big part of the whole system in treating these patients. When the physician is looking at a patient, he has basically 4 P's, what we say, to get the best outcome for any treatment that he's going to suggest him. First, he needs to predict what's happening, and he needs to make sure what's happening and what he's got to do. And he's got to look at also personalized treatment, what is going to suit for this patient. There may be so many people having the same problem, but each one's solution is different. Then he needs to look at prevention. Prevention is recurrence, it could be recurrence or prevention of any harm during the treatment process or during the surgery. And for all this, it needs to be a participation by all of his physician and care team and the patient and the families. It cannot be underestimated that the patient and their families have to be uh, compliant and really have to understand what the doctor is going to say and how he has to proceed further with the treatment, what's going on. It's going to take off a lot of the anxiety and make them more comfortable and follow the treatment. Even among the physicians, now we are going to talk mainly about the radiologist and the surgeon. So the 3D printing is a connecting link between the two. The radiologist is basically trained to tell stories from image data sets, say from CTs, MR scans, and he knows how to translate these stacks of like 300 or 400 2D slices he has to conceive in his mind. He's been trained to do that. But when necessary, he also thinks about the fluid flow. Whereas the surgeon, he takes the reports of the radiologist and he takes these images for himself and his clinical findings and puts everything together in his mind and tries to create a 3D version. What he's going to anticipate or is going to picturize in his mind what he's going to see when he's open. And in very complex cases, on-the-fly decisions are not infrequent. They really have to make a decision right at that point, whether to remove more of tissue or remove less, because they have to work between form, function, and removing the disease in total and things like that. And the surgical team communication is variable because you have all types of people. You have a co-surgeon, or you have the nurse, then you have the other people the support staff. You have the anesthetist. So it's different. And patient communication is again variable depending on the language barrier, depending on the mindset, depending on how the patient is able to process what the doctor is saying. Surgeon is very physical. He's very hands-on. I've been a surgeon myself. The very fact that I got here was when I used to do tumor resections of the jaw as a maxillofacial surgeon. I had no solutions. So when I saw this 3D printing some more than 22 years ago, I really got fascinated and came in. And today I'm really so happy that I came in here. I'm able to do much more than what I would have done as a surgeon. There are a lot of surgeons, but there are only few people who can do this. So the surgeon needs a touch sensation. So these models can be very comfortable for him to feel. And he is trained to perform also minimally invasive surgeries. They don't open up the patient completely all the time. And many times he operates with a light scope where there's very small space through which they pass the fiber optic scope and they do this surgery. But for most part, for these surgeries, they are only open surgeries. Additional information is always welcome to a surgeon because it prepares him better for the surgery. He gets to know how things are better. A surgeon, what is his goal and what does he need? He needs to operate the least amount of time. And he looks at the virtual mod. He likes to look at a virtual mod that he can move, rotate, highlight the pathology and simulate the surgery, make it big, make it small, do all kinds of things. And he can evaluate in those models what if situation. What if I cut here? Will I be able to completely remove the tumor? Will the patient be able to walk after this? Will my graft or will my replacement, reconstruction be enough? And how will I transfer all this surgical planning to the OR? Whatever he thinks prior, he still has to have a process by which he needs to transfer it into the operatory. And then he creates a template for this specific surgery. Then he also needs to get patient-specific implants, and he is looking for a repeatable fabrication. All these high stakes at an affordable cost. Affordable cost is underlined. He weighs all of this and makes sure that he's good with everything. So this is a preparatory stage. The surgeon's armamentarium for treatment planning. You have a preparatory stage, executive stage. During the preparation, he looks at the patient, looks at images, talks to people, collaborates with them, and then he comes up with the best plan. And here he's in his operatory doing this surgery. Bottom line, stakes are high. We are dealing with human lives. We are dealing with children. We are dealing with adults. We are dealing with all people. And expectations are both high from the surgeon point of view and the patient. The surgeon is expecting to do himself the best he can and to get the patient rid of the disease completely. The patient also expects that he gets released of his problems and he is comfortable. He is back to baseline. And post-surgical corrections are not an option. You can't do a surgery a particular way and then say, oh my gosh, I should have done another way. That it doesn't work that way. So you are given one chance. Of course, we do corrective surgeries, but corrective surgeries are very difficult. It's not only the cost factor, it's more trauma to the patient and healing is delayed, and the patient also feels hurt and his morale comes down to see whether he's going to be all right or not. It shouldn't be there. So we should give the best to our patients. Diagnostic imaging. What next after? How the diagnosis is made? From the imaging point of view, apart from other things, as you said, we're going to talk about imaging only today. You get a CT scan, you get an MRI, you get a PET scan, a combination of all of these three. We make 2 or 3 as needed, gives the best results. And here, the surgeon has everything in his hand. Now he has this stack of images. He's going to look through these images and make sure, like, where he's finding the problem, what he's got, how he's going to treat it. What if he would think, what if I had this? If I'm able to see through the patient, if I'm able to see the anatomy through, how nice it could be. Patients are not transparent. So his images, he can get into a transparent mode. So what if I remove the layers? Say I remove the skin and now I have just the rib cage. Now I can see the relationship of the tumor to the ribs, the chest wall, the hands and everything. This is a shoulder, and so now he's able to see exclusively the tumor. He can make this big, he can make this small. He can remove the tumor and see what the bone looks like. And all this is only on the computer. The next stage is going to be, okay, now I have a physical model. I have a printed model which shows me where the problem lies, and it gives me the relationship of the problem and helps me plan my procedures. This is how I have my surgeons. They look at the models and they make their great decisions. and patients are benefited. What do these models provide? They provide a good computerized structural details of the pathology and the normal anatomy. You not only need to know what's wrong, you need to know where the demarcation happens between the normal and the abnormal anatomy. And he gets a physical one which he can touch and he can pass it on to the team members. He can also use it for educating the patient and the family to get better compliance. And using this, they can also make very precisely fitting implants with optimized design. And there are lesser chances for infection because surgery which use this technology are found to take a good amount of time from the OR. Is going to reduce the time in the OR so that the time period for the patient is exposed is less, anesthetic time is reduced, so there's less chance of infection, faster recovery, and better patient compliance and family compliance because they understand what's happening. They are able. How is all this achieved? You have, this is a two-phase procedure. You have a design phase and you have manufacturing phase. During the design phase, you take the CTs and the MR scans because the CTs show the bone anatomy better, while the magnetic resonance shows the soft tissue part of the tumor better. So here you see how we use these softwares and hardwares. I personally like to use what's called Geomagic, which has a haptic device. So I'm able to actually feel these models on the computer and I have the tools exactly like what the surgeon would use who's in the operatory and do the surgery. So once you have created this virtual model, it needs to be made into a physical part. And thanks to 3D printing, it has made possible for us to print all of these models in very complex shapes. So it allows us to give different structures, different colors. We can make some transparent and some opaque for a see-through models. And these are all the technology. We'll not be going into all the technology, but bottom line, we know that there is so much of technology out there. This is an increasing field every day. It's been the buzzword during the COVID. And there's lots of new materials coming up, which helps us do things better.
Hey, Dr. Parthasarathy, back on that last slide, couple questions. You had mentioned earlier, it was like CT, MRI, and also PET imaging. And so you had mentioned CT is really helpful and MRI is great at showing soft tissue better. What about PET? Does PET add anything to this?
We use the PET, but not really a whole lot. Because the PET has a lot of images and the CT PET can be used, but most of these patients get more than the PET. The MR shows the soft tissue lining much better. So
that cool when you were showing those images, like was like the kind of the soccer images where you could remove the skin to reveal the bone. Is that so? When you're creating this modeling on this kind of software platform, do surgeons have access to that so they can kind of mess around? Like, is there, I'm kind of, really thinking almost about like,
absolutely.
Absolutely.
It is not that I create the model and I send them. Well, I do the groundwork. I have everything ready for them. Then there's always a meeting that happens between the physician and me. So we sit together on the same table, and he says, and he's the one who decides where he's going to cut and where he's going to do. So he moves the model around, makes it. And even before he comes in, I can send him a web link, which he can take a look at before he comes in. So he's prepared for the meeting.
Yeah, and I was actually thinking about like virtual reality, kind of like the Meta or the Oculus. Is that a thing that's
off late we have started using in virtual reality for a little more than a year, and we have the LUC system with us. We use it, currently we use it mainly for cardiology and so, some of the deeper structures, but soon we are opening it up because we wanted to get ourselves familiarized with the first things, and so um, we are opening it up for the rest of the hospital as well. So anybody can walk in, so we get it prepared for them. We use the headset. It's an amazing technology. But the only thing is, I'm looking for a day when the VR can also have a haptic sensing. Because as I said, that as a surgeon, I would like to touch and see. I would like to feel and see. The texture makes a world of difference to me. We do use virtual reality. So, and when you combine CT and MR, there is a lot of coordination that needs to happen. But even at the time of imaging or even before the imaging, when the physician asks for an MR or CT, the schedulers need to know that this patient has got to go for both together at the same time, so that we place the fiducial markers when they take the MR and the CT. So it's very easy to co-register. It registers really precise. When you have those markers, which show up both on the CT and MR. So you register, you get a composite model, then you do a 3D print. Then before that, you have the design here. This is the haptic device I was talking about. So this acts like a joystick, and you can actually feel the model. Then I send it to my surgeon. He comes over and we sit and discuss, and he is good. Then we design the guides as needed, if needed, and then we print them. The guide material is a biocompatible one, which can be sterilized and which can also go on the patient for during the surgery. So this is a virtual to physical transformation. You have a model made here. Now you see how the 3D printer goes. You can see how it's printing. So the technology we have here is highly precise, and it prints at 30 micron layers. And you will see that we can do multiple colors, and yeah. As it prints, it also deposits what's called the support material. Here the printer is done, and once the print is coming, it comes up with an envelope of waxy kind of material, which when washed gives these the parts. It brings out the parts. Then for some surgeries, we connect the parts here using magnets, so you can assemble them as they are in the patient. Now we'll see some of the clinical cases. We have this is a humerus tumor. This is an MR where you can see the tumor, and this is a PET CT where you can see the heat up area. So this is sarcoma of the humerus, and this patient went through a fibular reconstruction. So it was not an allograft; it was an autograft from the patient. So here we see how we have the skin layer. This is the overlay, and the surgeon coming and telling me this is where I need to go and do the cuts. Then we do the cut, and then we prepare a jig for them to cut. This is the model, printed model, where you have the cuts made and highlighting the tumor, and this is the printed jig. And this is done. All this design work is done through this. Then this is the fibula bone of the same patient. So after we do virtual surgical planning, we can take the same measurement from here, transfer it onto the fibula, and remove the fibula virtually and put it in the operated virtual model. And this is a post-operative proposed model. And this is the fibula guide. So the surgeon gets to do very precise surgeries. And it's going to take less time because everything is already prepared ahead of time. And here, this is the pre-surgical model with the resection plan. And here you see there's a post-operative X-ray. So you can see how this goes, really precise. Now this is another tumor where you see the green part is the soft tissue part. This is scapula, the shoulder. This is another humerus. And then you can see how the MR and CT is co-registered. Then you get this. And the fiducial markers really play a big part. Now coming to pelvic tumors, they are one of the most complicated issues. And because the function is really high, because it needs to be it needs to be load bearing, and the rest of the limbic system has got to fit into that. There's a lot. So here you see a patient having a tumor. This is the CT. This is the MR. Both are co-registered here. Has the CT part of the tumor. Then we do a combination. There's a composite model. Here we do a virtual surgical plan. The surgeon says, this is where I'm going to cut. This is the acetabular surface where the femur is going to fit in. The femur is good, so they're going to use the femur as such. So this is the model where you can actually see how the cut is made and how so much of data processing is happening. So how do we really confirm and make sure that things are right, things are exact, that things are precise? What we do is we take these models and then we put it into the CT scan again, and the printed model goes through a CT scan, just like the patient, and then we recreate the anatomy. Then we overlay it on the patient's data itself, on the patient's CT itself, so that when it tests exactly precisely on the patient's anatomy. This is another pelvic tumor. You can see. And I do have the model. When we go back to the video, I can show you a couple of models what we have. This is a tibia tumor, CT, MR combination, and then this is the surgical plan. Here we wanted to do two surgical plans. One is resect the whole of the distal part and then go for reconstruction. But the surgeon wanted to keep back the posterior part, so he could use an allograft. And so he used bone graft from allograft and got it. This is a printer we use for printing. Here you can see how through the transparency, you can see these lines are the guidelines for the surgeon for the resection. This is another distal femur tumor where you see this is a really a big soft tissue component is that we can also get the vasculature and the relationship of the vasculature to the bone and the tumor, so the surgeon can plan his surgery really precise. And this is where the preventive step comes in, where he will prevent any wrong thing happening to the blood vessel. So this is from safety point of view, it's really very, very acceptable. Here, this is another tumor. This is a sacral part. The tumor is both the pelvis and the sacrum. So this is another very complex situation where here's the virtual surgical plan, and then the model is printed and used in surgery. This is another pelvic tumor. So this is before, this is during the surgical plan, and here you can see how they can use these landmarks exactly to the cuts. So you can see the printer we have is a high-end printer, so we can do multiple colors. As we can use to, both flex materials and rigid materials, and we can combine both of them to produce materials with the intermediary properties. Recently, the advent of the digital anatomy printer gives you the ability to make these models with mechanical properties equivalent to that of bone, so that they, during the rehearsal of the surgery, they can actually place the screws and make sure everything is good.
That is so neat. So you knew that one of your previous slides you were showing, you could see the vasculature as well on the model. Is it the same with nerves? How are the nerves represented there?
Yeah, that is why we are able to educate the surgeons and the physicians to ask for these models at the time of asking the imaging. So when they ask for the imaging, the radiologist who's protocoling appropriately makes the images, because not all times the for printing we need to have thin slice data images, and it's so that they get us like 1 millimeter slice for MR, and for CT it is 0.5 or 0.625, and they get the image appropriately. If you need to see the blood well, they will do an angiography where they will inject contrast, or if we see the nerves, they will take up appropriate protocols. So actually, for some of these spine models, we look at the spinal cord and we put it into the vertebral column and show them. So we could see the nerves as well. But only thing is, it has to be done appropriately. The imaging has to be done appropriately. So these models also help to produce very precise custom implants. So one of our patients had a custom implant here, and that was very good. And these allow us to make the direct implant manufacturing. I had the opportunity of doing 3D printing with titanium as well before, and of course we don't do it with the hospital premises. It's a lot of processing needs to be done in an industrial environment, and but you can make titanium implants, you can make stainless steel, you can make chrome cobalt, you can use polyether ether ketone or PEEK, which is a metallic polymer, and then you also you can use PEC. All these some of the implantable materials. I'm not talking about bioresorbable implants. I'm talking about non-resorbable implants, which we see to be used as load-bearing implants for what we are looking at for today. Here, this is a cranial implant. This is part of my PhD research where you make these, because as we all know, titanium is very hard and dense. So you create the ladder structures, and you need these ladder structures to be both strong as well as lightweight, so you can optimize the design. And they are used as vertebral cages. They're used as a lot of that. Here you have some of the other orthopedic applications where 3D printed a stabular cup, and you can have the femur. You can see optimization of these ladder structures plays a part in both the strength and keeping them good. These are some of the manufacturing devices done by these the big guys. Benefits of these models and devices are gives a good comprehension of the structural details and the normal anatomy versus the abnormal anatomy. It gives a tactile sensation of the physical model for the team members to use. I had a great opportunity to be a part of the 3D printing expert for a conjoint lens separation at Texas. And that we had about 25 to 26 surgeons who were operating on that patient. So when they had this model, it was really very comfortable for them to pass the model around and do very good planning and do successful as well. It's not only for such complicated cases, for any patient, for anything, it's really useful for so you can actually show the patient what's happening, and they will be able to understand, and they understand the do's and don'ts, why it is told that they shouldn't do something or they should not be doing something. And these are life-size models, and so they are printed on a 1:1 basis. As we said, we have good family education and patient education on the pathology and better planning and compliance. You can make very precise implants, and then you have reduced operating time, there's a chance for infection, faster recovery, better patient compliance, as we saw already. Now we come to point of care manufacturing. What is turning around the past 5 years, I would say. About 5 to 6 years or even little before that, most of these devices or the printing models was made by the device manufacturers. And I worked in a device manufacturing company as well. We are the representative who drops off the CD, and then we do the design, we talk with the physician, and then we don't get to know too much of the clinical details. But with the advent of point of care manufacturing, there are many hospitals who have started this within the hospital, understanding the need for this. It is point of care manufacturing is a facility within the hospital. You have an engineer, or you have an doctor engineer like me, or it's an interdisciplinary reaction or interaction becomes very easy. And scheduling and appropriate protocoling cannot be underestimated, because the quality control starts from the imaging. And so if the MR or the CT is already done, there's no way the patient is going to have it a second time just to get these models. So it could be a compromised imaging, because imaging is not done with the model being made in mind. And it also reduces the lead time. I have a trauma patient who comes in this evening, going to be operated tomorrow afternoon. I can quickly make the model and give it to them, so that the surgery is better, the patient gets better treatment. So with all of this, a lot of hospitals are moving towards point of care manufacturing. The team also gets post-delivery feedback. So when I give these models, the next time I'm able to talk with my surgeon very comfortably and say, did it go well? Or I'm able to go into the operatory and see how they use a model and see what more I can do for them. So it's a continuous improvement process, which benefits both the surgeons and the patients.
Did you say that you were able to turn a model around in a day? Is that what you just said?
Yes.
Wow. I was wondering both time and cost, kind of what that was. But
again, it depends on the model. It depends on the size of the model to be printed. And if I need a pelvis model, there's no way I can do it. But if it is a limb, or if it is the and it also depends on the size of the printer that you have. So we have a pretty big printer. So some of our pelvis models, they take about 50 hours or 60 hours to print, and it can just go without being monitored. Say, but if it is a femur, a complicated comminuted fracture of the femur, I a lot of prints for the spine and other things, they are like overnight. So when I start the print at 5 o'clock when I leave, and the next day morning when I come, it's ready for cleaning, and I can do it quickly.
Like a gift waiting for you in the lab.
Oh.
Little present for you in the morning.
Yeah, because we do that all the time.
Yeah. So I'm actually curious because I'm kind of just remembering back from our own personal experience that the implant was ordered from another company, right? A kind of a third party company.
Yes.
Custom implants, so required many weeks, I think, for that to create that. And I'm wondering, in osteo specifically, because you have the neoadjuvant chemo, and it changes the tumor, right? And it changes what that looks like. And so
Yes.
I'm just curious how having point of care kind of affects that timeline, because I think in, 5 years ago, before this was more common, the planning started really early to allow time for the custom implant to be created at a separate, place, but then have to be sent in.
Yeah, that's exactly what happens. It's really very, in the lead time is definitely reduced. And if you have the expertise, you can collaborate with the manufacturer, do the design in-house, and even just send the design over. But that needs a lot of collaboration and in-house expertise. But usually what happens is they have a CT just before the surgery. So there is enough time for planning. But gone are the days when you would say that you need 8 weeks to do a custom implant. That cannot happen. And because, as you said, for fast forward, the anatomy changes. Even in normal people, there's always a process of bone resorption and bone deposition. And so it is tough. So you always have to give enough of provision for that, and it needs to be done pretty quick. And now the manufacturing also can happen that way. Yeah, you're right.
Yeah. So the planning can happen closer to the
closer to the surgery, because the surgery is the last thing the patient goes to. So so when we make these models, they are pretty close to surgery. Yeah. And how can we achieve all of this? You need a very robust quality control system, right from start to finish, right from the imaging, as I said. Then you need to have a diagnostic approved software for working, and you need to have trained people. There's not a whole lot of training that's going on at this stage. So there are a few knowledgeable people, and so of course it is happening, and you need to have personnel who can oversee the whole thing. And as I said, from time to time, you have to maintain your printers, you have to make sure your material is good, and we have a way by which we get after we do all the design, before we print it, we put it back on the patient's CT and look at it. And then after it is printed, for complex cases, we also do the CT of the model itself and put it on the patient. That looks and make sure things are good. So a quality control system is really essential. Patient, you have now the benefits again we're going to see. Enhanced visualization, seeing the complete internal external anatomy is possible, which is not even during the surgery, they can't see that. And better understanding of pathological anatomy, the tangible model, and possibility of surgical rehearsal, especially with materials that are coming up which have the same biomechanical properties as the human structure. And that's one of my greatest areas of interest. Then they form an intraoperative guidance so that they can use the anatomical landmarks. You can select appropriate devices. Ahead of time, you can have a library of screws that you're going to use, plate sizes, everything can be, inventory can be prepared before, so you don't have to go searching. And an updation of off-the-shelf products for patient needs, education, and another big thing is all these models, they make a big library for educational and surgeon training. We do our cardiology training once in 6 months for our fellows where they look at a bunch of these models. Then as far as this is for the patient and the surgeon, then you also have a confident surgeon because here's all the information he needs and he's going to have less requirements for on-the-fly decision. Patient is going to feel faster, and the cost is going to be decreased. Even though everybody's going to talk, oh, you got to buy a printer, you got to buy this, you got to buy that. Yes, you got to have the armamentarium to do that, but over a period of time, if you look at patients who have gone through this versus patients who have not had these models or patient-specific implants, the hospitalization time reduces and the healing is faster and they're able to get back to work better. And you have a coordinated team who, when multiple surgeons are operating, you have the surgical oncologist, then you have the orthopedic surgeon, and you have the nursing team. If everybody understands their role, you have a compliant patient who understand the clinical scenario, and they give informed consent because they know what they're doing. And then they have lesser chances for litigation. And is more, the patient is more compliant to post-operative instructions and helps himself to heal. And they can be either, they know why you say the do's and don'ts. And in conclusion, we can say provide greater accuracy for performing bone and soft tissue resection as they are based on patient's own data and precisely replicate the surgical plan, help to access the right location with precision, reducing time in the ward, chances for infection is less, and huge cost savings, which is reduced in terms of OR time. Every minute in the OR costs a whole lot in hundreds of thousands of dollars. So eventually, it'll all be good. A reduced duration of anesthesia, which is again safe for procedures. Decrease risk of surgical contamination because the patient is open for less amount of time. These are my references. And a question is going to come, is this all reimbursable? Not at this point in time. We need warriors and we need champions who are using this technology, where the RSNA, Radiological Society of North America, and the special interest group in 3D printing is working with a registry of surgeons and physicians using this and tracking the outcomes so that all this can be taken to the stakeholders and say, even though we may not have reimbursement at this point in time, we are reducing that. We'll be able to show them the numbers, how the operative time is reduced. our patients are getting better. With this, I end with acknowledgements to my oncology surgeon, Dr. Thomas Shashwat, who has been the backbone of all our work we do. Our radiologist, Dr. Mitchell Reese, who does the appropriate protocoling and helps us and make sure that we are doing things right. And our Nationwide Children's Hospital, Pediatric Advanced Imaging Resource, and our 3D printing lab folks. And last but not the least, our patients, for whom we work all the time. And when your child needs something or an intervention, we are here to take care of you. This is a light up of Nationwide Children's entry point during the lighting season. And thank you all. With this, I'm going to close my presentation, stop sharing my screen. And
Thank you, Dr. Parthasarathy. That was fascinating. Vicki and Walker, feel free to jump in with any questions that you have just based on your experience. I mean, I'm curious if this, well, actually, first question, Dr. Parthasarathy, what institutions is this available at? That outside of Nationwide, are there other institutions that have this capability?
yeah, as I said, that this is increasing over time. I'm Rudy's Children's in San Diego has, Boston Children has, Mayo was the first to start in 2008. Mayo started, and there is the Tampa General Hospital has, and and there are more hospitals who are coming into the fray. As I said, the point of care 3D printing is becoming more and more because people are starting to realize the value.
Vicki Walker, was this ever, I'm not sure what institutions you guys were at, but was this ever kind of presented to you as an option when you were planning your surgeries?
Not for
my
me.
only option. Really?
No. Yeah, I have never heard of any of this. So I don't know. I don't know if they do it. I guess I got treated at Cincinnati Children's, so I don't know if they do that now. But I guess I got my surgery in November 2018, and they didn't do any of this. I guess I do have one question though. So you said, or you talked a lot about like the models and how that helps prepare the surgeon for surgery. Do you actually 3D print any of the prostheses though?
We don't do it in the hospital, as I said, because the prosthesis you need to have a good a compliant manufacturing system, and that's a whole different ballgame. So it'd be like having a device manufacturing company within the hospital. So we partner up with the device manufacturers where we work on all of this and we create the base for them to start working.
Okay.
We started this program about 6 years ago, and at that time there was I think just about 4 or 5 hospitals. Like I'm not even sure if Rudy's had. Boston Children's had, and there were a few. And what happened was, it was basically there was one champion surgeon who was using it by himself with a small printer. And all this became bigger because the 3D printers started shrinking in size, and you could get less expensive printers so that they could people would be able to invest a little less comparatively when they start working. But when you're doing for diagnostic purposes, you have to have the software that is FDA approved and have properly trained people. I have a couple of models which I would like to show. Here, this is the pelvis model where you can see here, you can see how this is the uh, where the acetabular, where the femur is going to stick is, then the femur is going to stick. You can see all of this. Here you can see the marking, how the surgeon is going to cut, and this is one of the very early models which we made. Then here there's another femur. This is, I show, are you able to see it? Yeah. This is another femur. This is the end of femur. This is where it joins the knee. This is the knee joint. This is the distal end of the femur, yeah, the tumor. The red part is there is a tumor which comes from the MR. The bony part comes from the CT. And if you can see these lines are where the surgeon is going to make his cut and where he's planning his surgery. So when you overlay this, you are able to see that you give enough clearance. So you'll be able to, the surgeon said that this is a whatever type of tumor. He says, I need a 1 centimeter clearance from the last imaged tumor. I can precisely measure 10 millimeters from the edge of this tumor and then allow him to make his cut. So this is what we see we can do that. Yes, I thought you had some questions, Walker.
Yeah, no, that answered my question.
You did, okay.
Yeah, thank you.
Vicky,
I had a question coming from a personal experience. I'm just kind of wondering, like, has there been any recent developments more about like the durability of these? Because I know I was told, no running, no lifting over a certain amount, and they have to be replaced every like 15 years or something. But has there been anything of the works of improving them?
Improvement keeps happening as the research and things are happening. But the thing is, that there is, all this is very new. So we don't have any data on what is happening. You would be one of the persons who would be giving us the data. And probably some 10 years down the line or 15 years down the line, you will have enough number of people who respond. But as of now, we do simulate to see how much of load this can take. So based on that, on the simulation results, we give them the restrictions.
Great. Anything else, Christina? Yeah, no, thank you so much. I was just going to say, I like the whole point too about patient education and helping patients kind of understand, really kind of what some of the limitations might be, or kind of care, just being able to see it, I think is so helpful. And, maybe it's a nice souvenir for them at the end too. They can have the surgical team sign it because you don't have a cast. So you guys, Walker and Vicky, you could have everyone sign your pelvis.
I mean, they kind of had that before,
Not like that. So we gave him a small replica of his bone, but we really made it small and said, you don't want to have a whole size, a full size, but you can have a small size. Occasionally people do ask for some
Travel size.
size. Exactly. Small one.
All right. This was so interesting. I'm so happy you were able to spend some time with us today, Dr. Parthasarathy. Really appreciate your joining us on Osteobites and making it better for pediatric cancer patients everywhere. And some more information on this and all Osteobites can be found on YouTube, on our website at mibagents.org, and at your favorite podcast place. And we are going to be off next week because we are going to be in Atlanta for a MIB Mingle and to visit one of our 2022 Outsmarting recipients, Dr. Jason Eustein at Emory University. But we're going to be back on March 2nd with Dr. Kenneth Rankin. He is a consultant orthopedic surgeon at Newcastle's Freeman Hospital, the UK. This is actually going to be another interesting topic on surgical planning. Dr. Parthasarathy, maybe you can tune in. He is going to be discussing his work on sarcocyte, which is a randomized controlled trial of fluorescence-guided sarcoma surgery versus standard of care. So you can find our OsteoBytes lineup for the next few months on our website. And if you have any ideas for future topics that you'd like to hear about, please share them with us at events@mibagents.org. Thank you again, Dr. Parthasarathy, for joining us. And thank you, Walker and Vicki. Appreciate your being here, and thank everyone else for joining us here today on OsteoBytes. We'll see you in a couple weeks when we return with Dr. Rankin on March 2nd.